Okay, we move on to our last talk, Dr. Saksham Mathur, and Dr. Saksham will going to talk about comparison of lens and iris parameters in angle closure glaucoma versus open angle glaucoma in ASOT. Is Dr. Saksham here? Oh,
A very good afternoon to you all. I'm Dr. Saksham Mathur, a final year postgraduate from Maulana Azad Medical College. And today I'll be speaking on the very important and upcoming topic of comparison of lens and iris parameters in angle closure versus open angle glaucoma on ASOCT. First of all, why do we need to study about this topic? Because primary angle closure glaucoma accounts for about 50% of global glaucoma blindness, and it disproportionately affects people residing in Asia, that is us people. There are various pathophysiologies which have been discussed for the causing angle closure, including pupillary block mechanism, the iridotrabecular contact, and various lens and iris parameters which will be discussed in our study. Coming to the age-old discussion of gonioscopy versus ASOCT. Gonioscopy we know is the gold standard for diagnosing angle closure. However, it is a subjective test requiring a longer learning curve and most of all requiring contact. So in post-COVID situations, we have a newer modality coming up, that is ASOCT, which provides a rapid 360-degree view of the angle. It is an objective test and it is non-contact. Our study group included patients with primary angle closure glaucoma at any stage, that is PACS, PAC or PACG. And control group included age and gender matched open angle glaucoma patients which were undergoing cataract surgery. The parameters evaluated in our study were following. We did ASOCT by KCR2 machine, which is a type of swept source OCT. The parameters evaluated were lens parameters including lens vault, lens thickness, anterior vault and the relative lens vault, iris parameters like iris curve, iris area, iris thickness, angle parameters like angle recess area, angle opening distance, the trabecular iris space area, anterior chamber depth and the iridotrabecular contact index. Coming to the results. Our study included 81 eyes with angle closure glaucoma and 32 eyes with open angle glaucoma, and here are the results. Lens vault. What is lens vault? It is basically the distance between the anterior pole of the crystalline lens from the line joining the two scleral spur. It is a newer modality which is coming up and is a basic risk factor for causing angle closure. So lens vault was found to be significantly higher, that is 0.59 in ACG as compared to only 0.2 in OAG. The relative lens vault was also found to be higher in ACG, that is 0.24, and lower in OAG, that is 0.07. ACG patients were found to have a very bulky lens, as evident by the lens thickness, which is more in ACG as compared to OAG, and leading to a shallow anterior chamber depth in angle closure glaucoma. This is a slit lamp picture of a patient with a very high lens vault, that is 1.33. And corresponding to that, there is the ASOCT picture where we have highlighted the lens vault of 1.33. These are the iris related parameters. So ACG patients were found to have a lesser iris curve, a lesser iris area and greater iris thickness. What is the importance of studying these parameters? First of all, I want to point out that all our ACG patients had already undergone a laser PI, and a laser PI is known to alter the iris parameters. That is why a few previous studies which have been published have shown that ACG patients have a larger iris curve. But in our study, they were found to have a lesser iris curve because they had already undergone a laser PI. Iris thickness was found to be at 750 microns, slightly greater in ACG patients, implying a thicker iris in ACG, which also contributes to angle closure. This is a ASOCT picture showing all the parameters studied in our study. We also did a correlation study between the post-op IOP reduction and the pre-op ASOCT parameters, and it was found that post-op IOP reduction was positively correlated with pre-op iris curve and negatively correlated with the iris thickness. The limitations of our study included that there was a significant difference in sample size, that is 81 eyes of ACG and 32 of OAG, so which can produce a bias. Then all of our ASOCT of angle closure was done post-PI. So in our future study, we plan on doing ASOCT in angle closure pre-PI for better parameters. And in ASOCT, as we all know, we need to manually identify the scleral spur, which leads to various biases in identifying and the scans. Now, how do we utilize this study in our future clinical studies? We need to generate a normative lens fault databases because it can be used as a screening tool predicting the angle closure risk of the patients. Planning surgery in ACG patients. The patients which have a higher lens fault were found to have greater intraoperative difficulties. So we can plan an early lens extraction in them. And ITC index is an upcoming parameter which is an objective method in addition to gonioscopy for quantifying angle closure and for counseling the patients, as we can show them the scans and tell them these are your angle closure potential. Thank you.
In your study to justify that conclusion.
Yes, previous studies have shown that PSC patients have a greater lens fault as compared to PSCG, but we didn't do that analysis in our study.
Yeah, because that was the important issue, because your conclusion was,
Yes.
you know, that you could do it, but your data doesn't support that. Okay, thank you very much. Any questions?
Why did you choose POAG as your control group? Why not normal? What is the
Ma'am, we are undergoing another study. We are comparing ACG versus controls. So that is another part of the study. And then we plan to combine all the two studies and compare PACG with OAG with control group for better idea of how to plan them surgically.
so you but you have not presented the normal
that
paper.
study is still undergoing, comparing with healthy controls. This study included only ACG versus OAG.
Thank you.